It's really a great honor to be here, to be able to discuss with this distinguished group of experts in this field on how to improve the quality of care in CKD. These are my disclosures. And my talk is divided in 3 parts. I will begin by presenting the challenges, the 3 key challenges, from a translational scientist point of view. I'm not a nephrologist. Please forgive me if I have limited knowledge in nephrology, pharmacology, epidemiology. I will follow to present the approaches I think that may be able to help to address those challenges. There are 3 proof of concept examples I will present here, and trying to demonstrate how kidney biopsy approach can help to identify those non-invasive markers and thereby facilitate the precision medicine in kidney disease. So let's start with the challenges. And we know that not every patient with CKD will progress to the most advanced stage or to the end stage of kidney disease. And we also know that if we start treating those patients with high risk early, this makes a difference. But the challenge here is how to identify those patients at risk in a very early stage. So we're not doing a good job there. And challenge 2, in terms of the treatment, we know one-size-fits-all treatment does not work, not only for kidney disease, but for all other diseases as well. So on the left figure, you will see only a very modest proportion of patients will respond to the treatment of the top 10 best-selling drugs in the US market. So I think when the patients come to the clinic, they're facing to the nephrologist actually facing with the question, there are increasingly more treatment available, but each of these treatment only works for a subgroup of the patients. And then how to identify these drugs and best fit to these particular patients and match them. So this is a question. Currently, we do not have a evidence-based quantitative measurement to help the doctors to make this decision. And when the treatment started, and we have the question after a short time period, and can we predict whether this drug this patient currently is taking will have a long-term beneficial effect? So this is a challenge as well in the current situation. So all these challenges conclude to the urgent unmet need of the biomarkers, well-risk biomarkers in kidney treatment. So we need diagnostic biomarkers, and that can tell us what type of disease this patient have. And we need prognostic biomarkers to identify those high-risk patients and to answer the question whether we need to treat this patient or not. And we also need predictive biomarkers to help to answer the question what type of treatment this patient specifically needed. And we need the dynamic biomarkers. And so after a short treatment of period, and then the doctor can answer the question, does the patient need to continue or probably change to another medication? So therefore, actually, we need more biomarkers and molecular mechanistic biomarkers more than GFR and ACR to help us answer the questions. And because we know that there are limitations of GFR and ACR in the following area. So first, it's not sensitive, particularly in the early stage. And you know that patients with substantial kidney damages, for example, based on the Pima Indian study, and there are intrarenal damages, but still have normal range of ACR and GFR, and they are less effective in prognosis at early stage. And also, they're not sufficiently representing tubular interstitial injury. They are very good markers and for established disease and for the glomerular filtration, for the gloom damage. And last but not least, and it is not able to provide insights into the molecular mechanism and suggest for treatment. I think that is a disadvantage of these two markers. And how to find those molecular markers that I was talking about. And because kidney disease is initiated, manifested in kidney, we have to look into the kidney to try to answer these questions. There are various risk factors that contribute into the pathogenesis of kidney disease and progression, and from the healthy and to the injury. There's listed only these a few, but definitely not limited on this. And we want to understand under each of these risk factors what kind of molecular mechanism being activated in there, and therefore for more accurate modeling, monitoring, and even treatment. So thanks to the advancement of high throughput technologies, and we can obtain those molecular profiling across the phenome to genome, from the genome to phenome continuum, and we can associate those genes, proteins, metabolites with all these clinical variables and with outcomes and with inflammation and fibrosis and albuminuria, hypofiltration, all these phenotypes. And then we can look into, in this set of genes and proteins and metabolites, whether we can detect them non-invasively as a non-invasive marker. So in the next few minutes, I'm going to present 3 proof of concept examples and to tell you how the kidney biopsy can contribute to the identification of prognostic biomarker, predictive, and dynamic biomarkers. And first start with the prognostic biomarker. Based on the transcriptome data and from a large cohort of 164 discovery cohort, and our group, VG Nair and Kirby Shedden, identified a set of genes whose expression in the kidney associated and can predict the kidney function quantified by GFR. And EGF is the epidermal growth factor, is one of these markers, and have shown that the expression of EGF RNA can predict the kidney GFR in the discovery, as well as 97 of the validation cohort. And using samples from 2 independent cohorts from Neptune and C-probe, and our group can show that the urine protein, EGF protein, is highly and significantly associated with the tissue EGF RNA level. And that allows us to break the dependence of the biopsy and look into the urine EGF level to use it as a surrogate marker to represent what happened, what the EGF RNA level in the kidney tissue, how that varies. And then we looked into the urine EGF association with the tissue, interstitial fibrosis, tubular atrophy, and GFR, as well as GFR slope. We can see significant association between the urine EGF, can be biomarkers for those 3 parameters. And lastly, and we found the urine EGF protein and can independently predict a composite endpoint and demonstrate additive value to clinical variables. These are adjusted for GFR, ACR, and age and gender. And as you can see in 3 independent cohorts, the low level of EGF is associated with increased risk of kidney progression. The 3 characteristics of EGF and makes it a good prognostic marker. First, kidney specificity. EGF is only expressed in the kidney out of a panel of 79 human tissues and cells. And that tells us the urine level of EGF is really a production from kidney alone. And in the kidney, an EGF expressed specifically in tubular epithelial cells, and particularly in distal tubule cells. And that is representing a tubular function. And so I think that is filling the gap that current clinical variables mainly measuring the glomerulus function. And EGF is not a damage marker, but rather a regeneration and repair marker. In a paper published in 1980s and by Dr. David Humes, and he showed that in the acute kidney injury, if we treat these animals with EGF, and it shows is accelerated recovery, meaning EGF indeed in the kidney have a function and to accelerate the repair and regeneration of tubular cells. And that study has been replicated in the next, and see 6 additional studies. So the effect, the positive effect, mainly carried through the receptor activation and then through 3 pathways: JAK start pathway, and MET kinase pathway, and PS3 kinase pathway. And since the paper published 2015, and EGF has been validated across CKD subtypes, including diabetic kidney disease and general population, and transplant recipients and pediatric chronic kidney disease have in over 1,900 samples, and we could show that EGF improved the prediction of a risk of CKD and progression. And additionally, the low sample volume of EGF for measurement, 4 microliter of urine samples, is needed, and as well as the stability of EGF, it is not affected by pre-analytical conditions and can be measured accurately after prolonged frozen stage, making it appealing for the clinical application. So now I want to present another example for predictive biomarkers, meaning before the treatment of patient, to give a guidance what treatment should that be. And very elegant work and carried out by Laura Mariani, Sean Eddy, and Fado Alcava from our group. And they used a unbiased clustering analysis for 220 Neptune patients. Those are patients with nephrotic syndrome. And the clustering showed from all the gene expression of those 200 patients, clustered these patients into 3 groups. And cluster 3 has showed a significant increased risk for progression to composite endpoint in comparison cluster 1 and 2 patients. When we looked at those genes that are differentially expressed between cluster 3 versus the other 2 clusters, we found those genes, they have a top regulator, master regulator, which is the TNF. And TNF, through regulating the downstream gene network and influence associated with the significant increased risk. And the question is, can we create a TNF activation score for each of these patients? So, and then the group looked for those genes that downstream TNF and specifically regulated by TNF. And 128 genes being found, and their expression was used to create a Z-score, and we call it a TNF score. So we calculate for these 220 patients with FSGS and minimal change disease. As you can see on this waterfall plot, and on the left, from left into right is a ranked score of the TNF. On the left side, there are patients with the red color. They are the group cluster 3 patients. They have higher TNF activation score. But on the left side, all the green and blue color, and they are the patients from cluster 1 and cluster 2. As you can see, there is a huge variation of TNF activation in those 200 patients. And the question is, if we use the TNF inhibitor to treat those patients, and we can probably imagine that on the left side, those patients could benefit the treatment, and on the right side, and they may not, because their pathway is not activated, and they may even have adverse effect. So this is the question, and which fits to a 2010 a clinical trial led by Howard Trackman. He used TNF inhibitor to treat those patients with FSGS and found that out of 16 patients, only 4 actually responded to the TNF inhibition and had a significant drop of proteinuria. The other patients did not respond, and some of them even have really adverse effect. So, and then, since all these patients, 200 patients, have the biopsies, and the next question is, can we identify non-invasive markers and use that as a surrogate to correlate with the intrarenal TNF score? And just measuring these markers, we already know what the TNF activation is. So, and the group looked into those downstream genes and proteins that regulated by TNF and identified MCP1, which encoded by CCL2 gene, as well as TIM1. And they further looked into the urine level of these proteins and then associate with the TNF score of the same patients, the matching urine biomarker and the tissue of the TNF score. And they found very nice correlation of this urine TIM1 and urine MCP1 correlate with TNF and can be considered a negative, as a surrogate marker. And then using a predictive model and with urine MCP1 and TIM1 predicted the score, and the predicted TNF score is highly and significantly correlated with the tissue intrarenal TNF score. So therefore can be used as a marker to predict the score. And based on what I alluded in the last few slides, and Debbie Gibson and Howard Trackman initiated a precision medicine proof of concept trial. And in this trial, they recruited only those high-level TNF, TIM1 and MCP1 scores, and then treat with the TNF inhibition and want to look into the biomarkers change, and then later on after this step and associate with longitudinal outcome of effect. So I'm going to move on to the third example, and that is the dynamic biomarker to predict longitudinal outcome. So as many of you already know about the SONAR trial, in SONAR trial, the doctors used atrasentan, which is an endothelin receptor antagonist, to treat the patients with diabetic kidney disease. And this drug has been shown effective in phase 2 clinical trials in preclinical models and reducing proteinuria and fibrosis inflammation. So in this trial, we can see the atrasentan treatment significantly reduced the risk of progression in those diabetic patients. And however, despite the promising effects and significant effects, and there are still patients in SONAR receiving atrasentan and still experienced a primary renal endpoint. So this shows there is a huge variation. And our question is, can biomarker help to identify those patients who do not or at least respond to this drug treatment, and therefore for better patient care? So this study was funded by BEAT DKD and led by Dr. Hido Herspink, who is sitting in the audience. So in this, the group used models with in vitro models, the cell lines, using the animal models for diabetic kidney disease. And those are all treated by atrasentan. We also collected the samples from the patients from the reader, and urine samples, serum samples, plasma samples, because those clinical trials do not collect kidney biopsy. Therefore, we have those cells and animals to help us understand what is the mechanism there. And transcriptome data have been derived from those models, and metabolomic data, proteomic data, microRNA data have been generated for those patient samples. So the goal is to identify what kind of molecular pathways are associated with the atrasentan treatment in this study. As we can see, and we put all these different molecular features from different high-throughput technologies and identify those pathways only supported by more than two omic data support. So that is more reliable than just having one. So as you can see, the endothelin activation, which is the drug-targeted pathway, is activated in the animal models in the diabetes versus control. All the pink key molecular signals are upregulated. And after treatment with atrasentan on the right figure, and you can see those pink, which indicates activation, turn into green. So meaning atrasentan treatment indeed reversed this endothelin activation in the kidney. So in addition to endothelin signaling, other molecular pathways are also enriched in those reversed gene or protein regulation, as you can see, supported by multiple omic data, that including certain signaling pathways and NRF2-mediated oxidative stress response. Those all have been associated with diabetic kidney disease or regular KID or normal CKD. So I'm not going into very much detail on those, and if you have questions, we can discuss later. And importantly, we want to get to the specific biomarkers. And in the phase 3 SONA trial, we identified patients that responded to this atrasentan treatment, which is the group 1. They have reduced ACR, they have stable kidney function. We also identified patients from two groups of patients who do not respond to atrasentan, and they still show a very steep GFR slope and do not show any, not show in good improvement of albuminuria. So those patients being matched at baseline level with all the risk factors, and then we used SomaScan, the 1.3K, to simultaneously measuring 1,300 proteins to associate those change. As you can see, the urine samples being collected at baseline and then 6 weeks after the treatment. So we use the change of the biomarkers after 6 weeks of treatment to associate that with the response effect. And though identified markers, and four of them significantly predicted the response of atrasentan also in the validation studies, and we used ELISA to validate the SomaScan results. So currently that study is in preparation of the manuscript. And so kidney precision medicine, and in a simple word, is finding the right interventions for the right group of patients at the right time. Right time is early time, no doubt about it. And I hope that you can see that based on what I showed in the past few slides, the prognostic biomarkers and predictive and dynamic biomarkers is critical to apply those precision medicine. And also, and kidney biopsy, as well as the molecular profiling of the biopsy, the gene networks, the protein networks, and is helpful to identify those biomarkers. So, and this has been recognized by NIH as well, therefore started 2017. The kidney precision medicine projects are being launched, and the goal of this KPMP is collect the biopsies from AKI and CKD patients, and to create a kidney tissue atlas and define disease subgroups, because this is not lump up all the patients together. We want to understand more about specific subgroup of patients, what pathway is being activated, and identify new treatment and based on those subgroups. And importantly, that patient play a very important role in this KPMP project. They are not only donate their tissues, but involved in decision making. And by now, 160 biopsies from AKI, CKD have been collected, and those cutting-edge technologies from omic technology as well as non-omic, the imaging technology being used, applied to generate very rich and high-resolution data. As you can see, single-cell and single-nuke data have been created, and also that combined with the spatial transcriptomics, spatial proteomic, and metabolomic data. So all this allows and further high resolution of phenotyping of the patients and to allow us to integrate those molecular signatures with a phenotype. And currently, the version 1 atlas is available, and that really can help us to look into the cell types, stadiums, health stadiums, and also the cellular neighborhoods. And all this data being available from Kidney Tissue Atlas webpage, and the raw data can be downloaded from here even before the publication, right after the data generated and QC applied. And the Atlas viewer is for people who do not have much bioinformatic information, but can look into that, ask the question, why the gene, where my gene of interest is expressed, or the cell type that I'm interested in, whether they have a specific list of markers expressed in that specific cell type. And you can also, using the spatial viewer, to look the regional and spatial transcriptomic and proteomic data. So are we there yet? And so at least in the Gloom disease field, and the precision medicine is applied, and led by Matthias Kressler, the Neptune study has initiated Neptune Match. So the biomarker being measured for those patients, and then based on the marker, and the doctors can have a better feeling about which pathway of these patients have been activated, and that allows us to match individual patient molecular disease mechanism with the pathways those different drugs targeted. And this trials obviously is an independent, ongoing nephrotic syndrome trials. So this is one step with the right trial for the right patient at the right time. With that, I conclude my presentation and thank all the people listed here. It takes certainly more than a village. I thank Matthias for the long time support. All my colleagues in University of Michigan, the BD-KD Consortium, and Hido and Maria really supported some of the projects, and CPROB, Neptune, and KPMP. Most importantly, the patient community and scientist community. These are crucial. Without them, this is not possible. And lastly, I want to say this is an amazing time, and for precision medicine in kidney disease, let's just do it. Thank you for your attention.